There's, just to say it cleanly, she said intrusion into an otherwise busy scheduled day, vital emergencies, necrotic emergencies, like failures that were previously treated cases and they're failing, and then there's the big field of trauma.
Okay. All right, well, let's now look how to handle a vital emergency.
The kind of emergencies I recognize.
Well, tell us about vital emergencies and how you would manage those.
Well, when they say on the phone, cold kills me, sometimes they'll even say warm water turns the cold pain off. You know that that's going to be a tooth that's vital. It's going to bleed excessively when you open it. There could even be anesthetic issues, get them profoundly numb. And so one tip I'd really like to tell the audience is when you reproduce the chief complaint, and we've done other episodes that we can refer the colleagues to go get information on the vital pulp test, hand signals, and how to record this information. But given all that, essentially what you want to know in vital emergencies is you test the tooth last. So you would get a baseline, contralateral teeth, opposing teeth, and then do the tooth you suspicion, the culprit tooth last. If you provoke a huge pain with cold, okay, now everybody knows you got the tooth. So then you usually follow up with anesthesia. And let's just say for fun, it's a lower mandibular molar. So, they say the lip is getting profoundly numb. They're starting to talk like this because they're so numb, their tongue's numb. So all of a sudden you're going, okay, let's isolate. And you've just told the patient, we do endo all the time. It goes very, very well. I am the king of endodontics and my patients never hurt. So you isolate the tooth because they're profoundly numb. And you start to drill and all of a sudden they're jumping around in the chair. So that means they're not properly anesthetized. So what the trick is once you have the patient profoundly numb, come back and retest the tooth with a cold stimulus and see if they feel it. If they feel it, you're going to need auxiliary anesthetic like Stabident or an interligamentary injection to get another level, a higher level of profound anesthesia. So, Ruddle missed one maybe because, there's a lot of different tricks for supplemental, but sometimes infiltrations, we're talking about a lower molar as an example, a buccal infiltration, sometimes a lingual infiltration. But the two that I mentioned one and didn't mention the other, is we have the ILI, the interligamentary injection, and that's very, very effective. And then we have the intraosseous injection, Stabident would be an example. I guess I did say it, but I wanted you to know you can go either way. You can go through the bone, put a drop or two into the cancellous bone, or you can go right into the ligament and there's a big gun type device, as you know, that's so you can get enough pressure to overcome that tough PDL, periodontal ligament, and then you'll get a few drops going down, and then you can usually go right to work.
I had a question. So if we're just looking at some of the differences, attaining anesthesia could be more difficult for a vital emergency than a necrotic one.
Bingo.
And then I'm wondering about the bleeding, because you said that these teeth might bleed more, a vital emergency. Now, is it ever the type of situation would you say it's bleeding too much, we need a knot? Like, can you work on a tooth if it's bleeding excessively?
Yeah, the blood can be, to be very visual graphic, the tooth is isolated, right, everybody? There's a rubber dam on it. Okay, I understand not everybody uses a dam, but I'm talking about the tooth's isolated, the blood's coming up out of the pulpal floor, it's coming on up the axial walls, and it can spill over the top of the tooth and start to run around the rubber dam that's isolating the tooth. So I'm talking about significant bleeding. And of course, you got to get vital tissue out of there. That's why they're hurting so bad. That's why they're an emergency. The reason we're making a big deal about this, we said anesthetic could be a problem. Check. Bleeding could be a problem. Means more time to give the anesthesia and get all that managed properly so you have their confidence for life. Blood's coming out of one canal. Okay, extirpate the pulp out of that one canal. Go to length. Just like Rick did, except in the vital case, go to length, make the amputation because there's a neurovascular bundle coming in. not the bundle down the inferior alveolar nerve bundle, but a smaller little bundle is coming in the foramina and related portals of exit, and it's coming up into that tooth. You want a clean amputation, and you've removed the inflamed tissue. So what's the point? Time. Time. So you want to pick these off with the receptionist and how she interviews the patient. I think we're going to talk about that.
Right. What would be like on a vital tooth, and say you were very busy that day and you were just trying to do maybe the bare minimum? What would you consider to be the bare minimum?
There's typically in a molar, just a second ago you heard me conveniently say there's one canal. Well, when you open up a molar, there could be 3, 4, or 5 canals. Well, we're not going to have time. Remember, it's an intrusion, otherwise busy schedule day. We're not going to have time to go into 3, 4 systems unless you cancel the next patient. And sometimes you have to do that. Sometimes based on circumstances, where they're from, where they're going to be tomorrow. Okay, maybe they're on a plane tomorrow. Well, you better be pretty definitive if they're going to go on a plane tomorrow. So you might need to shift your own internal schedule or have them come back, maybe the same day later. But what you probably need to do is have a team that really understands what's going on in your office. And you might be able to catch the next patient before they've driven to the office and find out how they're doing, because what if they're an emergency? So you can't just say, would you like to change your schedule? No, it's killing me. Okay, so you need to ask people questions, and questions are the answers. These shouldn't even be a surprise. I mean, I guess one thing that gets me irritated is we're even talking about this like it's a surprise. Like, I will say it, have the receptionist interview the patient. They're calling, they're in a lot of pain. How long have you been hurting? Since yesterday. Last night I didn't sleep all night. Okay, very short duration, but very intense. Well, it's been like this for about 2 or 3 weeks. Okay, that's a different kind of an emergency. They're finally calling you because they're really worried about it. And so you don't trivialize their concerns, but what if they say 2 or 3 months? I've had many people say, well, it's been bothering me for 2 or 3 months. That's not a real emergency, is it? It could have been seen tomorrow. You could have seen him yesterday, later this afternoon. How about next week? Okay, so ask questions. How long has it been hurting? Another thing I want to know is, how much does it hurt? I mean, you're the patient. It's not me. We're taking your word for it. We believe you. 0's perfect. 10 is the worst you can imagine. Where are you at on a 0 to 10 scale? Have them quantify it. Okay, and then the next thing is there any stimuluses that elicit this kind of a pain? As an example, can you drink a glass of cold water? Oh no, cold kills me. I got to keep. Okay, it's going to bleed. So before you ever say, could you come in, and you give the time and the day, you already know it's going to bleed like crazy. It's a vital emergency. If they say no, cold water, I can put cold on it and it makes the pain go away. Necrotic emergency, okay? So, I mean, you can have that receptionist not do the Spanish Inquisition, but they can ask 3 or 4 intelligent questions and know right where to plug them in so they disrupt the office as least as possible.